actually, there are hundreds of hospice providers just in the Los Angeles area. So how do you go about selecting a hospice? So, like I mentioned earlier, whatever hospice you choose, they are all regulated and have oversight by Medicare. So, in theory, and hopefully in practice, all hospices are following the same Medicare guidelines. However, we have found in the Los Angeles area especially, there are for-profit hospices and not for-profit hospices. And again, they're all governed in the same way by Medicare guidelines. But our personal bias, Marianne and I, is that we feel that this not-for-profit approach fits a little bit better with our mission and values at Little Company of Mary Hospital, where we are especially attentive to, of course, those who have access to resources, but also those who don't have access to resources. And many nonprofit hospices are that way because they have a better focus on providing care to everyone, regardless of need. If you ever came to a point where you were going to need to choose a hospice, by law, you are supposed to be given a choice. So if you were ever in the situation where someone was saying about your mother or your loved one, it's time for hospice, and here's the hospice you will use, that is, in fact, a violation of the law. By right, you have the right to choose. So how we do it at our hospital is if someone is going to leave the hospital and go home to hospice with hospice services, go to a nursing home with hospice services, go to an assisted living with hospice services, they are presented with a form that thankfully doesn't list all the hundreds of hospices in the area, but lists what we feel are probably the 5 or 6 that we work with most closely, and we can feel confident recommending them. However, again, our bias, Marianne and I, even though everyone has the right to choose, our bias is toward Providence Little Company of Mary's Hospice, which is called Providence Trinity Care Hospice. And so oftentimes if patients and families don't know of a hospice, they will choose Providence Trinity Care Hospice. They've been happy with the care at Little Company of Mary. There's a sense of continuity, there's a sense of being known and having your medical records and your history already kind of being in our Providence system. And it feels nice to be a part, kind of under the same umbrella. So hopefully that answers your question. It's a difficult time, everyone's under stress already, and then to feel like you're making a choice can be even more stressful. So I would just file away in the back of your mind, though, that it is absolutely your right to make that choice for yourself.
Is there any evaluation services that evaluate each one of them or identify complaints associated with them?
Yeah.
I don't think it's quite as structured so far as the nursing home industry is. But for instance, Providence Trinity Care Hospice is one of the few accredited hospices. So you look for things like that. It's fully accredited by an organization that accredits hospices.
It's different than JACO. JACO accredits hospitals. There's a different
It's called CHAP, and it's the special accreditation for hospice. So you might look for that kind of accreditation.
So that might be a good thing to add to your living will and things of that nature, that you do that when you're conscious.
Great idea, right?
Good idea.
Right? Yeah. You could even designate which hospice.
That's a good
yeah.
idea.
Are there particular things you should look for when looking at the hospice, or particular questions you should ask?
That's a good question. So she asked if there's different things you should check into. So technically, because hospice is a service that's covered by Medicare, Medicare sets the guidelines for hospice and requires that all hospices provide the same range of services. So they all will have a medical director, they will all have nurses and home health aides and social workers and chaplains, and so they all technically have the same things, but as you know, there are still differences, and a lot of it depends on the personnel. The number of years they've been in existence would be a good question, because some of them pop up and pop down. You know, Trinity Care Hospice has been around for, gosh, over 25 years. So you look for things like that: stability, longevity, who they're associated with, nonprofit versus profit. Those are the kinds of things you would have to ask. And then you just sort of have to see if you can interview them before you accept them. They all provide 24-hour care. You know, they'll be responsive 24 hours a day. They have to do those things. They at least have to say they do them.
I don't know. How do you see the Affordable Health Care Act improving the quality of care we get through either hospice or palliative care?
Like I said, I think that the palliative care is really at the we're on the horizon of, you know, so much more palliative care. I think that the emphasis is going to be on staying home, keeping people healthy. That's really what palliative care is about, is keeping folks like you all, you know, as active, and like programs like this would be considered part of a palliative care approach to your illness. So I think that there's going to be more and more covered in that way. I think that hospice, as Denise was saying earlier, at some point they're going to expand the criteria for hospice, because too many people feel they have to decide between this and that, when really, you know, in some situations you should be able to get both. There might just be one oral chemotherapeutic medication that would help you, maybe not cure you, but could help you, but you know, you should still be able to get hospice. So eventually we think there may be some changes, but not yet.
Down here first. Yeah.
Yeah, I was going to ask, in hospice or even in palliative, what about if you don't want to use some of the services, like you don't want a social worker involved or you don't want a chaplain involved?
Yeah.
Is that still your choice?
Absolutely.
Yes.
You always have a choice in hospice to choose whichever services. I believe the only absolute is you have to accept your nurse.
Okay.
Yeah, because that's kind of the basis of hospice.
To qualify for a hospice, do you have to be within a certain time limit of end of life?
Yes, the doctor, in order to be eligible for hospice, you have to have a doctor say that they would not be surprised if you would pass away within 6 months.
So 6 months or less?
Yes. Yeah. Yeah. It still is that. Although, having said that, you can stay on hospice much longer. We all know people who've been on hospice for a year or two. And sometimes people sort of stabilize but are still very sick, and they can still qualify for hospice for much longer. So hospice would only kick you off, so to speak, if you got significantly better. And that sometimes happens, and that's a happy situation for everyone. Yeah.
If you're really sick and in your directive you have no respiratory, no the machine,
Ventilator.
no ventilation, and all of a sudden you need it, but in your will it says no.
It's a good segue.
That is a good segue. So we're just going to start now talking about kind of advanced directives, how you let people know what you would want if you're really sick, in terms of things like ventilators, things to help you breathe.
Well, I was on a ventilator. I was very sick a few months back, and my husband signed me off because I said no.
Ventilation.
And we didn't understand it was temporary.
Oh, that's a really, these are hard issues.
There's a fine line between them.
Yeah, look at you. Yeah, beautiful. Yeah. Very rich. So these are very tough questions for all of you folks, actually. Because the whole question of, you know, whether you would want to be on a BiPAP machine, or if you would want to be on a ventilator, short term, long term. And so we're going to talk a little bit about that.
Yeah.
So these are hard questions because sometimes there's not just one answer. And the most important thing is that your loved ones kind of know what your intentions are. Because as much as we write anything down, it's really our conversations with people who would make decisions for us that are the most important.
So this paper in front of you that says at the top, can you and your loved ones answer these questions, is a tool to use to have that conversation. So as Bibi pointed out so well, a piece of paper that has a checkbox answering yes, I would want everything to keep me going as long as possible, and then the only other choice is no, I would not want everything to keep me going on as long as possible. If I don't, I'm not going to get better, is kind of a blunt tool, if you will. It doesn't really capture the nuances of the situations that happen every day in ICUs all across the country. So as much as those documents are very important, and we want everyone to have an advance directive or living will, and we're going to talk about another document in a moment, we also want to emphasize very strongly that as important as those documents are the conversation and conversations that you have had with the person or people who are willing to speak for you, if there's a time when you can't speak for yourself, and willing to follow your wishes, even if your wishes differ with their own, and just someone who knows you and what makes your life worth living, and what kind of situation would bring about you saying that's enough. What kinds of things, if you lost them, if you could no longer do certain things like walk or talk or eat or recognize family members, what things, if they were taken away, for you would compromise your quality of life to the degree that you would say, please let me go. So this tool, we want you to take with you, and we want you to choose someone, think of someone's or several someone's, who you could sit down with over coffee, or over tea, or over a meal, or over the phone if the person is far away, and say, you know, I know it might sound morbid, and I'm not planning on going anywhere soon, but these ladies came and gave this talk, and they said I had to do this. These 5 questions really help clarify for someone who is going to need to make a very difficult decision, like Bibi's husband, more of the nuances. So the first question is a continuum rather than a yes or no question. It's in general, how aggressive do you want doctors to be with your treatment? Because the default in the hospital for doctors is they will do everything all the time, meaning CPR, ventilation, all of the powerful medicines that restart hearts when they stop, the powerful medicines to raise blood pressure when blood pressure goes down. That's the automatic. And if that's what you want, then you would be more toward the 5 end of the continuum. Don't give up on me no matter what. Try anything, proven or unproven. Some people fall more toward the other end of the continuum. They would say, you know, if it's at that point where I need all of these very powerful technologies to keep my body going, it's actually okay to let me go. People often say things to us, I've lived a full life. I have my affairs in order. I know that my children are going to be okay. I know that my spouse is going to be okay. So it's okay to let me go. In fact, some of those things, doing them to me might cause me suffering, so please don't. So it's very likely that everyone in this room is on a different point on the continuum. So the idea would be to go through this and the other questions. Many people haven't told anyone if they have a preference, if they are at the end of their life, if they would rather be at home or in a hospital. And by having this conversation, you'll be able to answer questions 3 and 4. So a loved one will be able to describe how you'd like to be treated. And this person will be someone you trust, who will, like I said, follow your wishes, even if they have a different view about what they would want for their own care. And then again, the bottom question, number 5, does recommend the pieces of paper are important. The advance directive, the living will, the living trust are important as backups. But don't forget to just fill out the form and not have a conversation with anyone. And now Mary Ann's going to introduce you to this next form. So the best description I've heard of this pink form, it's called a POLST, which stands for Physician's Orders for Life-Sustaining Treatment. Is an advance directive is for a situation where something unexpected happens. You usually prepare those earlier in life when you are relatively healthy. A POLST is a form that you absolutely want to have if you're in a situation where if something were to happen and you were hospitalized, that wouldn't necessarily be that unexpected. You might have a chronic, long-term debilitating illness, and you might have had several hospitalizations. So this can be a very important form at that stage of things.
So the first question is, has anyone completed this form? Anybody here? All right, we have some winners.
POLST, you have a signed, raise your hand if you have a signed POLST with
Big
your
sticker.
doctor, you get the big
Raise your
sticker.
hand, man. Just raise your hand.
You guys both did. Marvelous. Wow, this is great news.
More people than we thought. This is great. Good for you.
Anybody? Okay.
I know.
One of the things I wanted to respond to, like Phoebe's question about the ventilator. You know, that's a big question for folks, is whether or not, for you all folks, is if you had so much trouble breathing, would you want to be on a ventilator? And so some people would say no, if it gets to that point, I would never want to be on a ventilator. Some people say yes, of course, I would want to be on a ventilator. And there may be sort of an in-between. So in the hospital, you know, what happens if you come in respiratory distress, you're having trouble with breathing, is likely they're going to ask you, and you're going to be short of breath, and oftentimes the answer is, of course, I want help breathing. And so you would be put on the ventilator. And so always the hope when you're put on a ventilator is that they'll be able to wean you off. You know, that you'll get better from whatever infection or whatever that's causing you to have trouble breathing, and you will get better, like Phoebe obviously did. And so that's what happens. Sometimes though, you know, say after a week or two, things don't get better. And so then, you know, that's just where the conversation is important with your loved one. Because after a couple of weeks in the hospital on a ventilator, you can't stay on a ventilator with the intubation going down in your mouth to your lungs for very long, because it damages your throat and is not a permanent solution. So after a couple of weeks, they're going to ask your loved ones, if you're not able to answer, which usually you're not because you've got sedation going, they're going to say, would that person want a more permanent tracheostomy to be hooked to a ventilator? Okay, and so that's what the question becomes. So people have stronger feelings about whether they would want that. Because if you would want to have that, that means a whole lot of things. That means that likely you're going to have to go to a long-term care facility for we don't know how long, and maybe permanently be attached to a life support machine. So that's a bigger question. Sometimes people do that longer term and can still come off eventually. Sometimes they don't, and it's a more permanent situation of being cared for and being dependent in a long-term care facility. So I'm just guessing Bibi might say next time, if there is a next time, we hope not. You know, I wouldn't mind being intubated for a short time, but if it gets to the point where I would want to need a tracheostomy, I may not want that. So it's, you know, it's having these more difficult, fine-tuned conversations, which aren't really addressed in these forms. The forms are a guideline for your doctors and for your caregivers and for your loved ones to follow. But they can always be changed. But it's more important, like Denise said, about the conversation. Right?
After learning about Bibi's experience, I had my doctor and my daughter come with me to a doctor's appointment. And I told them the story, Bibi. And one of the things is her doctors here called, may I say this? Called Mexico? Called Mexico where she was. and interceded for her, told the Mexican doctors what to do for her.
Yeah.
And I did say to the
They had
doctor,
to intubate me to bring me back.
Or you were in Mexico?
yes.
I was in Cancun.
Oh,
She was in Cancun, so her two doctors were on the phone instructing the doctors in Mexico about what to do for her, which is wonderful. And I said to Dr. Abe, would you do that for me? And he said, yes, of course. But I did have my daughter there, and I said, together, my two kids, two of my three children, and you, Dr. Abe, will make the decision, because you all know me the best. So let's talk about what I want, and then together you decide whether or not that fits what I want.
But that fine line we didn't understand was, after 3 days, they put me on a respirator, and my husband came in and had a fit because he knew I didn't want that.
Right.
But we didn't know there's a decision between a permanent.
Yes, exactly.
Temporary.
That's what he explained. to me,
temporary.
Yeah.
Especially for folks like you all. You know, it's common to get pneumonias, which we're hoping you don't. We're hoping to get flus, things like that we're trying to prevent. But if they happen, sometimes it can be temporary, and just a brief time on a ventilator can help you get better.
I think
But
it's
if
a
it
good-
goes the other way, what would you want? Would long-term, for some people, long-term in a facility on a ventilator would be okay. Others, people would say, no, if it's long-term, I want no part of that.
But it's really a good idea to have whoever else is going to make the decision, one of your kids or whoever's going to make the decision,
Absolutely.
with your doctor. Because then they
Exactly.
can- It was really a good experience for me.
Let me just jump in
Yeah.
before we take your
Yeah.
question. Another thing that we're all kind of talking around the edges of, that I think is important, very important to reference, is if anyone in this room has had to be in the very extremely difficult situation of being looked to by the doctors to make a decision for your loved one, but you've never had the conversation with that person. The person has never prepared any documents indicating their wishes. That is an incredible burden to bear. A burden that, as researchers have begun to follow people who've been put in this situation, they've had a loved one in the ICU, ventilated, they've had to make a decision. Those people are actually showing up to often have symptoms of post-traumatic stress disorder. It is a traumatizing experience for children, spouses, relatives, friends, to have to make a decision flying blind. And people walk around, we meet them all the time, carrying a burden of regret, of questioning, of doubt, of
Blame
often
God.
judgment by others, of why did you do that? You killed them, you were playing God. It's an extremely difficult situation. So even if you really are not wanting to do this for yourself, you could also approach it of doing this for the persons who you will hope will speak for you. It's an incredible gift to your children, to your spouse, to your loved ones.
The question I had was, what is is there a possibility?
Two girls are gonna talk about, so, no whispering and chit-chatting, and turn off your cell phones while they're speaking. They donate their time.
Can you hear me okay? Okay, I'm gonna like these with my big voice. Yeah, thank you so much for having us back. We were here, I think, 2 years ago. Was anybody here 2 years ago when we were here to speak? Does anybody remember? A few people did. Great. So Denise and I work at the hospital with the palliative care consultation team. And so we see people in the hospital who have more serious illnesses to help them with decision making going forward, to help them with pain management, management of shortness of breath, other symptoms they might have. We work as a team with our doctor, Dr. Komatsu, in the hospital. So we hope that we never see any of you in the hospital, although we might. And if we do, we hope that you'll already have some of these decisions or have talked about them with your loved ones.
You have to, yeah, you have to.
Do you want to drink?
You haven't just about kissed that thing.
Yeah, it's almost like this one, right? Yeah, very good. Okay, so we're going to start today, Denise and I are going to start with sort of a little quiz for all of you. We have some candy prizes, and we just ask you to participate by raising your hand if you would like to answer the question. These should be pretty easy, but we'll see. Okay, so can someone tell me if palliative care is the same as hospice care? Palliative care is the same as hospice care. Okay, so could somebody raise their hand and then give us a reason why it's not the same?
Help yourself too.
Maybe she doesn't know yet.
Well, we'll take it back if she's wrong. So Sandy,
Palliative care, it helps you currently. Hospice is brought in when you're almost at the end of your life.
ding, 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 ding. Did everyone hear that okay? So palliative care, Sandy told us very accurately, can help you right now. Palliative care is about managing symptoms like pain and shortness of breath when you already have a serious or chronic illness. Hospice care gets involved, like you said, more toward the end when a doctor has determined that there is a likely prognosis of 6 months or less. So that's something very important to remember. Many people think palliative care and hospice are the same, and they're not. So thank you, Sandy. Well done.
Yay, Sandy!
All right, next question, and you all are getting the drill. If you raise your hand, Marianne will run over to you, and first hand up in the air gets the candy. We'll try to be fair. All right, if I accept palliative care, that means that I can't get any more aggressive medical treatment.
No.
Raise your hand if you, okay, over here or here.
What's your name?
Alicia.
This is Alicia. Tell us why.
I think that you're probably able to do both.
Good answer. So, she said false, that you are able to receive palliative care and still get aggressive medical treatment. So with hospice, oftentimes you give up your more aggressive medical treatment in lieu of comfort care. But with palliative care, you can still be getting chemotherapy, radiation, go back and forth to the hospital. Palliative care can be received at the same time you're still getting aggressive medical treatment.
Great. Great. Okay, I'll be looking this way. We haven't been very fair to this side of the room there. Oh, did you have a question?
I have a question about that. Would that include, if you have palliative care, could you still get therapy?
What kind of therapy?
Physical therapy? At the
Yes.
home?
So the question was,
Still
still come from the home. Yes. So the question was, if you are getting palliative care, can you still get a physical therapist coming to the home and doing physical therapy with you? Absolutely yes. Absolutely. Great question. So palliative care is an add-on service to all of the other medical care you're already getting. And you would want to add a palliative care team or palliative care physician or approach to your care when you need specialists to help you live with the symptoms of a chronic illness. Their goal, a palliative care team's goal, is to give you as much quality of life, meaning symptom-free life, as possible. So if that means physical therapy, then physical therapy is a part of it.
How does the finance associated with palliative care?
How are the finances associated with palliative care?
Okay, so Palliative care is a relatively new medical specialty, and it's still being developed. So right now, physicians, palliative care physicians could see you at the hospital, and he could bill like any other physician for his services when he sees you. Palliative home care is something that we're all hoping is in our near future. I think with Obamacare and things going forward, there's going to be great interest in keeping people as well as possible and out of the hospital as much as possible. So there's going to be more of an emphasis on palliative care at home. But right now, there is no formalized payment for palliative care at home. Some palliative care physicians are seeing patients as outpatients, and we're actually in the process of developing our outpatient program, where a palliative care physician could see you as an outpatient. Just like you would go to your pulmonologist, you might go see your palliative care physician.
Would you need to be referred by your doctor, or is that something you could look into on your own?
So the question is, do you need to be referred by your doctor? Good question. Or is that something that you can look into on your own?
So with palliative care at Little Company of Mary, to see our physician, you need to be referred by your doctor. That's something also that likely will change. So stay tuned. I think eventually it will be much like any other specialty. As long as your insurance would cover it, you could go see whichever doctor you like to see.
Oh, you're ready for
Oh, next question. You have to give up your physicians in order to receive palliative care.
She's already answered it.
Yeah, you did already answer it.
Okay, we got a consensus on that.
Okay, so no, you don't have to give up your attending physician. But we want you to have your attending physician.
Can I ask a question about that? Who are these people who would make up this team? Who?
Okay, at the hospital, the team is, we have our own palliative care physician, and then we have a chaplain, Denise, I'm a nurse, and we have a social worker. So it's a full range. Palliative care is very much interested in whole person care. So we take into account all of those areas, your psychological status, your social situation, your spiritual situation, and your physical situation. So we try to address things on all levels. That's who is the palliative care team at a hospital.
Great question.
Oh, thank you. Oh, I love Snickers.
Good.
Just take one.
Who's the physician? Can you tell us?
Sure.
Oh, yeah. Good question.
Yeah, that is a good question. Our physician at Little Company of Mary is Dr. Glenn Komatsu. Some of you may have met him. Tall, Asian, long hair. He's been doing it for quite some time, and he's very beloved by his patients and the community.
Will more doctors be joining that group?
Good question as well.
Oh, yeah.
Give her a Snickers.
She's on a roll here.
We're going to have a party.
There's not going to be any more Snickers left.
So yes, we are in need of more palliative care physicians because it is a new specialty in medicine. There aren't enough physicians that are specifically trained, and we are in the process right now because Dr. Komatsu is a very busy guy, and we need another physician as we speak. So we're in the process of interviewing, but it takes some time to find the right person.
Are there any doctors in the house? Here?
I wonder if they're pulmonologists.
It's still not quite clear. Is palliative care covered by Medicare or is it not covered by Medicare?
So yes, palliative care physicians will bill Medicare. Okay, next question. Palliative care is only for people with cancer. No.
Who wants to win? And tell us why.
Man does. Give it to man.
No.
Kurt hasn't won yet.
No, give it Tammy and Nancy.
No, I'm embarrassed, no.
She's already having a party with it. Okay. So we have to take
You
it back
can
and
come
you
to my
can't tell
party.
us why. So why is palliative care not just for people with cancer?
It covers people with all sorts of medical issues. It's not so restrictive.
It covers people with all sorts of issues. So what about heart conditions,
Yes,
lung conditions,
all conditions.
all conditions? What about an appendicitis?
No, because that's an emergency.
Very good. Should I give him another? I think that
Yeah.
I'm really thrilled over there.
Yeah, you answered three
I'll take
questions.
your
You can share it with your friends.
You won enough, Beatrice.
Oh, another stickers, yay.
So palliative care is for anyone with a serious medical illness, serious or potentially life-threatening illness. Okay. Choosing hospice means that I'm giving up.
No, they come in to help you.
So, a difference of opinion.
I didn't mean.
Prepare for the end of life.
Right. Okay, you sound like you have a good answer.
Yeah, okay. So does choosing hospice mean you're giving up?
No, it means that you're just choosing someone to help you towards the end of your life.
Just, you're choosing, yeah, to help you transition, having someone to help take care of you when you're toward the end of your life. Does anyone have a different feeling? There were maybe, does someone feel like, oh, hospice is all about giving up? Anybody want to talk about that? Oh, we have a hand here.
I feel hospice is kind of giving up because you're kind of saying, okay, I'm ready to, go towards the end of my life. Like this is the end.
So giving up in a realistic way, not
Acknowledging, yeah.
acknowledging.
It's acceptance.
Right.
An acceptance that all of us one day leave this earth. None of us has got the eternal ticket while we're here. So yeah, in that sense it is giving up, like Marianne mentioned earlier. Unfortunately, thank you for reminding me. Notice that she wasn't going to let me get away without. Like Marianne mentioned earlier, unfortunately, the good news is that hospice, the benefit of the service of hospice, is paid for 100% by Medicare. That includes the medicines, the equipment, and the team that comes to help the patient and their family. But because of that, because they're running on a shoestring budget, hospice can't afford to have someone receiving hospice services and receiving chemotherapy, or receiving hospice services and other aggressive treatments that tend to be quite expensive. So maybe someday there will be some changes, as Marianne has mentioned, as healthcare changes, there might come to be more flexibility in that way. But right now, many people do feel like it's giving up, or maybe a different way to say it would be foregoing or accepting a change of focus in the way you want your care to go. And hopefully that happens when you decided that what's most important to you is spending as much quality time as possible in the place where you want to be, which for most people, most Americans, is not in a hospital, not in an ICU, not hooked up to machines with tubes where you can't do the things that give you joy and give your life meaning. So that's what hospice is about.
Also, hospice helps the family members to understand and to help them to go through the different stages of the person that is
A very good point. Hospice also helps the family. They help the family right in the moment by training the family how to take good care of their loved ones. They help the family with the social worker and chaplain visits to talk about the different psychological and emotional and spiritual issues that come up near the end of life. And then when death happens, hospice continues to follow up with the family for a year after their loved one passes, helping you through the grieving process, making sure you have all the support you need to adjust to life without your loved one. All right. You guys are too smart, huh? So we'll have to skip some of our easy questions. What about this one? So a lot of people, oh, you already have a hand up, yes. Bobby knows the answer before the question.
I had a question. You mentioned that palliative care was to help people with their quality of life. Are you involved in inpatient discharge procedures as far as establishing home care? And would that include the delivery of oxygen for oxygen-dependent patients?
Very good, Dan.
This guy's on a mission.
Yeah.
It's a great mission, too. It's a great mission. So how it works in our setting, as Marianne mentioned, our team right now, and we represent the inpatient part of the team. So we don't go to people's homes, unfortunately, and we are just working on setting up a clinic for people to come see us. Right now, if one of you were to come into the hospital and it was determined by your physician that really to enhance your quality of life you need a certain service at home, if that's oxygen or otherwise, we coordinate with the home health care team and we pass off that information and the things they need to know about you to take good care of you at home. And we let home health take it over from there. Another sidelight, though, not everyone knows, sometimes people feel that hospice is just about morphine. And hospice is also, in addition to providing medicines and equipment, hospice also provides oxygen, if needed, as part of the comfort care, as a covered part of the Medicare benefit.
And with that is they don't require, in hospice, they don't require to know your oxygen level. They don't require you to have a certain oxygen level in order to qualify. Hospice provides it to you regardless.
Repeat your response, please.
So hospice doesn't have a requirement of a certain oxygen level. They will provide oxygen to the patient regardless, as long as any time that it is needed for the person's comfort. So a related question, and we hear this a lot in our setting in the hospital, is when we talk about this medicine that most people have heard of called morphine, there's an association with it that morphine makes you stop breathing. So the last question, and if you're going to raise your hand to answer, be prepared to explain why. If I get morphine, will I stop breathing?
No.
Who wants to bravely raise their hand and explain to us why? Anyone?
Okay.
Here we go. All the way, let's go with that.
All the way to the back.
Yeah.
He was taking the burger.
I always ask for it. I ask for it every night so I can sleep. When I was in the hospital.
We'll make sure you get two.
Yeah.
Take naps. Would not, because you give somebody morphine knowing that it's going to kill them, that contributing to his death. And that's
No, not unless your doctor could work it.
So Z said that she doesn't think so. She doesn't believe that giving morphine would make someone die, because if we were doing that, that would actually be killing someone. And so You know, people have a lot of different feelings about morphine. It brings up strong, can you hear me all?
Yeah.
It brings up strong feelings in people about whether or not they would want pain medication. And as you might know, there are conditions where morphine really helps somebody with their pain or also actually with their shortness of breath.
Yep.
And so people at the end of life who have shortness of breath do benefit from having morphine. Oftentimes it's given in very small doses. It's titrated very slowly by the physicians to a point only where the person would be comfortable, not with the intention of causing them to die faster or to cause them to stop breathing. Now, having said all of that, some of you, because you have lung issues, know that sometimes you've heard that morphine and medicines can decrease your respiratory response. And so in those situations, doctors are even more careful. But it doesn't mean that you would not benefit in some time from having morphine. It doesn't exclude you from getting it. It just means the doctors have to be smart, knowing what your conditions are and how to prescribe the morphine. But morphine can be very beneficial, particularly at the end of life, in helping treat symptoms like shortness of breath. Do you have a question, Becky?
I have a comment.
Yes.
When we went to CSPR, our conference up in Sacramento, they were talking and presenting lots of data and information on giving morphine to people with COPD in very, very low doses, and people that were still alert and ambulatory and functional in their life. That the morphine, the way they described it, it kind of blunts the brain from feeling the shortness of breath. The brain can no longer acknowledge it, so there is a trend that is starting up of giving people that are still active and going to church and into enjoying their lives minute doses